Welcome to The Explainer. Today, we're diving into Chapter 11, Approaches to Working with Young Children Who Have Attention Deficit Hyperactivity Disorder. Now, if you've ever spent time around young kids, maybe you have younger siblings, or you babysit on the weekends, you know firsthand that they have an absolute ton of energy. They run, they jump, they ask a million questions, and they literally never sit still. But how do we know when that energy is just typical childhood behavior and when it's, well, something more? When does a high-energy kid actually cross the line into needing clinical support? Today, we're going to break down the realities of ADHD in early childhood. We'll look at how it's defined, the major hurdles in diagnosing it, and how we can actually support these kids in the real world.
Okay, here is our roadmap for today so you know exactly where we're going. We'll be covering 1. Defining ADHD in children. 2. Diagnosis and misidentification challenges. 3. What causes ADHD? 4. Treatments and interventions. And 5. Supporting children and families. Let's get into it.
So what does ADHD actually look like in a preschooler? We all have these preconceptions, right? Maybe you automatically picture a kid just bouncing off the walls, or you think of a toddler throwing a massive tantrum at a restaurant because they absolutely refuse to sit in a high chair. We've all seen that happen. But let's step back and ask ourselves what the clinical reality really looks like in an early childhood setting. Young children are naturally active, and their impulse control is naturally very low because their brains are still developing. Spotting true ADHD means we have to look past those normal developmental milestones and look at the strict clinical facts. It's about recognizing behavior patterns that are far more intense and disruptive than what you'd see in a typical preschooler.
All right, let's jump into Section 1, Defining ADHD in Children.
So the DSM-5, which is basically the ultimate rule book for medical professionals, defines ADHD as a neurodevelopmental disorder. But the absolutely crucial point here is that it breaks ADHD down into 3 distinct categories. That means it doesn't look the same in every single child. First, you have the predominantly inattentive presentation. Think of the student staring out the window, totally losing track of time, forgetting their homework, and struggling to organize a task. But they aren't physically disruptive at all. Second, you've got the predominantly hyperactive impulsive presentation. This is the kid who physically cannot stay in their seat, blurts out answers, and acts like they're driven by a motor. And third, you have the combined presentation, which is exactly what it sounds like, a mix of both. It's so important to remember this is a persistent, long-term pattern of development, not just a kid having a rough week.
Now, what happens when it comes to getting services in a school setting? Well, the Individuals with Disabilities Education Act, or IDA, actually doesn't have a specific standalone category just for ADHD. Instead, it places it under the umbrella of other health impairments. But here's a really fascinating detail. For young children, especially those from birth to age 5, it's often temporarily labeled a developmental delay. And this is actually a highly protective, really helpful approach because it is incredibly hard to confidently distinguish true ADHD from typical high-energy toddler behavior. Educators use this broader label. It gets the child immediate support without slapping a permanent, potentially incorrect medical label on them while their brain is still doing so much early developing.
Moving right along to Section 2, Diagnosis and Misidentification Challenges.
Get this. You might be completely surprised to learn that young boys are 3 to 4 times more likely to be diagnosed with ADHD than young girls. 3 to 4 times. Why is the gap so massive? According to the research, it's often due to slower natural brain development in boys compared to girls of the exact same age. Plus, think about early childhood classrooms. They're typically designed with behavioral expectations that favor sitting quietly, coloring neatly, and following directions immediately. Those expectations naturally clash with a lot of young boys' normal developmental timelines. So a boy's perfectly natural active behavior might be mistakenly flagged by a teacher as a medical issue, simply because it doesn't fit the quiet culture of the classroom. On the flip side, we have some seriously troubling documented systemic issues leading to the underdiagnosis of Black and Latino children. The data shows clear disparities in who actually gets help. This ranges from implicit biases among clinicians who might mistakenly view a minority child's behavior as just oppositional or defiant rather than a symptom of ADHD, all the way to powerful cultural stigmas surrounding mental health care. Imagine the compounding difficulty of facing a language barrier while trying to navigate complex healthcare costs and clinic access. When you put all these factors together, it's a perfect storm. Many minority children who desperately need early intervention simply fall through the cracks and never even get an evaluation. And here is where things get really confusing in early childhood education. Let's talk about gifted students. The high energy of a gifted child who is simply bored out of their mind can look absolutely identical to the clinical hyperactivity of a child with ADHD. A gifted and talented child might challenge authority because they're super curious and want to question the rules. Or maybe they completely disengage and fidget because the worksheet they got is just way too easy. An educator might look at that disruption and immediately jump to the conclusion of ADHD. But here's the real twist. A child can actually be both gifted and have ADHD. We call these students twice exceptional. Whether a child has ADHD, is gifted and talented, or is twice exceptional, this overlap can lead to a heightened sense of alienation and profound frustration when their behaviors are completely misunderstood by the adults around them. These twice exceptional kids aren't just acting out to be difficult. They are experiencing a massive internal tug of war. They might have incredible cognitive strengths and grasp high-level concepts easily, but they completely lack the executive function to organize their thoughts on paper or wait their turn to speak. To genuinely support them, we have to celebrate those high-level strengths while carefully managing their deficits, making sure we don't just constantly compare them to their neurotypical peers.
Let's move to Section 3, What Causes ADHD? Okay, it is time to completely ditch those playground myths about kids acting out because they had way too much sugar, ate food coloring, or watched too much TV. Science tells us definitively that ADHD is primarily a mix of strong genetic components and environmental factors, like exposure to prenatal toxins or severe maternal stress. These factors physically disrupt the brain's executive functions. Think of executive function like the brain's internal air traffic controller. For a person without ADHD, that controller safely manages incoming thoughts, emotions, and impulses, lining them up for a smooth landing. But for a child with ADHD, that air traffic controller is missing or just totally overwhelmed. Thoughts and impulses crash into each other, making it physically harder to filter distractions, hold on to a memory, or stop themselves from shouting out. On to Section 4, Treatments and Interventions. Exploring treatments is obviously a huge decision for families, and it usually comes down to two main paths: medication and behavioral therapy. Medication, like prescribed stimulants, is incredibly effective. It reduces symptoms for 70 to 90% of children, helping them focus almost immediately. However, the American Academy of Pediatrics actually recommends behavioral therapy as the first step for young children. This comes down to a really interesting skill versus pill dynamic. Medication handles the immediate symptoms, sure, but it doesn't teach the child how to actually cope. Behavioral therapy actively teaches lifelong skills on how to adapt, self-regulate, and develop healthy relationships. Now, therapy can be costly and demands a heavy time investment from parents, but studies show that a combination of both medication and therapy usually yields the absolute best results. Finally, Section 5, Supporting Children and Families. So what does this look like in the classroom? Well, when a child has ADHD, teachers absolutely do not need to dumb the curriculum down, especially considering what we just learned about twice exceptional students. Instead, teachers need to modify the environment. They can use simple, direct language so instructions don't get lost in translation. They should intentionally build movement into the daily routine. And they can practice proximal control. That's just a clinical way of saying the teacher keeps their physical body close to the child's desk to help ground them and keep them focused. It's all about keeping the academic challenge high, but changing the way the child is allowed to engage with the material. To build emotional skills, educators use tools like the ruler model. RULER stands for recognizing, understanding, labeling, expressing, and regulating emotions. Think about a time in your high school classes when you were just overwhelmingly frustrated about a test or a friend. If someone just looked at you and said, "Calm down," it probably didn't work at all, right? It might have even made you angrier. Kids with ADHD are exactly the same, but they also struggle with the executive function needed to process that feeling. They need structured steps. The ruler model gives them a predictable way to identify what they're feeling, like connecting physical sensations to specific emotion words, so they can safely manage it before it turns into a total behavioral outburst. Another game changer is the social story. A social story uses 4 specific types of sentences: descriptive, perspective, directive, and control sentences. It walks a child step by step through a specific situation so they can safely anticipate exactly how they should act. Take going to the school library, for instance. Instead of just barking at a child to be quiet, a social story explains who will be there, why voices need to be low, and exactly what the child can do if they feel overwhelmed. By explaining the why and the how in advance, you remove the element of surprise, which massively reduces a child's anxiety and impulsive reactions. Because consistency is absolutely key for a child whose brain is already struggling to organize information,
Using a daily report card creates a powerful partnership between the classroom and the family. It's a quick, timely way to communicate back and forth every single afternoon. This ensures everyone is reinforcing the exact same positive behaviors and keeping track of the child's specific educational goals. For a child who struggles with executive function, having the exact same rules, expectations, and rewards at school and at home provides the ultimate safety net. It removes confusion, helps them feel far more secure, and allows them to make significantly faster progress.
As we wrap up this explainer, I want you to step back and think about all these complexities. We've covered the nuances of misidentification in twice exceptional students, the systemic barriers minority families face, and the environmental supports that can completely turn a child's day around. ADHD isn't just a label for kids who have too much energy. It's a very real, complex neurodevelopmental reality. Going forward, ask yourself how you can use this knowledge. Whether you're thinking about the disruptive kid in your own high school classes, your younger siblings at home, or the kids you might babysit or tutor in the future, how can you foster a more understanding, patient, and supportive environment for them? Keep that in mind and keep learning.